Dr. McEachern. How are you?
I'm doing great.
Good. Good, man. Thank you for coming in today. I appreciate your willingness to talk about this. This is a hot topic for a lot of people, but you penned a study that got published in JAMA, the Journal of American no, the Journal of the American Medical Association. There we go.
Yep.
And you have penned well over 150 of peer-reviewed journal articles. And this one happened to be reviewing the number of OBGYNs available in the state of Idaho since the end of 2022 to Christmas Eve of 2024.
That's right.
And we can get specifically into those dates, but this is something that's really, really important because whatever people feel about the trigger law and Idaho's position on women's reproductive care, whatever it is, irrelevant to me. What I want to know is how that is affecting the supply of OBGYNs for Idaho women and their families, daughters, sisters, everything. And then just make it clear to Idaho, it's like, hey, if this is what we want, that's totally fine. People can vote that way. And if it's not what we want, that's totally fine. People can vote that way. But let's just have clarity about what the policies are and what the effect is, which is, again, why I invited you, is what the effect is on our healthcare access. So if you wouldn't mind, explain to me the study and explain to me what you guys found.
Okay, that's a great question. I mean, the study's not fancy. A lot of the studies I do involve fancy statistics, and they have sampling involved and all that kind of stuff. This was real simple. This was like, take off your socks, pull out your hands, and count on your fingers and toes how many people are there. So my co-authors, Dr. Deb Roman and Alan Traylor, and I got together actually in June of 22 and said, hey, there's a change in the environment. The Dobbs law got passed. And we said, we think there's a right that's been taken away from doctors and patients. We think something's going to happen. We don't know what's going to happen. Some change will occur in this environment, and we'd like to be interested, and we'd like to figure out what it is that's going to happen. So there's a database called a PCOS database, which is kind of an interesting database because it's a credentialing database, it's an administrative database, and it's a Medicare database. So you have to be 65 years old to be in Medicare. But what it does have is it has every doctor in the United States who takes money from the government, which is essentially all of them. And we use that as a start. And then what we did is we went around and we actually got from that the people who were OBGYNs in the state. And then we actually validated that data set using commercially available data. We also used the internet. We also used our network. I've been in this market since 1994. I know a lot of these people personally. And if we didn't know the doctor personally, we know somebody who did know the doctor personally. And we asked them what kind of medicine they were practicing.
Okay, so just to sum up, you start out with, okay, every single doctor that takes money from the government, which is almost all of them, that is saying they're practicing OBGYN care.
Right.
And then you're like, okay, we directly called them.
Yep.
We checked professional databases. We checked, all of these things to actually verify, okay, this is the original number that we started with at the end of 22.
That's correct. And what you find is,
Here, let me move this real fast. There we go.
Okay.
There we go. There you are. Okay, keep going.
What you find is that this PCOS database has people who were licensed to practice medicine in Idaho who've never been in Idaho. They may be doing telemedicine or something like that. And there are people who have entered the market that are not in the database yet that we can find out. And so what we did is we looked for every person, every obstetrician. So there's OBGYN doctors who do things that are not obstetrics. They can do GYN only. They can do pelvic floor surgery. I mean, they do things that are not obstetrics. And we wanted only those who are practicing obstetricians to be counted. So at the end of August 30th, 2022, in Idaho, we had 268 obstetricians practicing obstetrics.
And that does not count the telemedicine people, right?
Doesn't count telemedicine. Right. It does. One of the things that I wish we had done, but we didn't do, and we have another study in the field. We didn't look at family medicine doctors who practice obstetrics or nurse midwives. And we've got a study looking at what's happening to those that's in the field. Don't know what that's going to show yet because we haven't analyzed that data. Another thing about this study is that a lot of studies are sampling studies where you go out and you say there's, like if we were to do this in Texas, there's like 20,000 OBGYNs and we would take a sample of those and we would say, this was what happened to the sample in Texas, and therefore we could infer another set of doctors left or came based on our sample. This is a cohort. This is every doctor who's practicing obstetrics in Idaho. We not only looked at where they were in practicing, we also looked at other offices that they might be practicing in. Some doctors have more than one office they practice. And we studied, what's the effect on the offices, and we also studied the effect of what happens with the doctors. So we go a year, and we repeat this the 30th of November, 2023. Get together, go through the analysis. We then validate that. We call our friends, and we do the same sort of research we did. And we were very, very picayune about this because we wanted to make sure that this data is valid and accurate and reliable. We had 210 doctors who were practicing obstetrics at the end of November 2023.
So again, to be clear, 268 to 210. So we lost 58.
Yep. So we actually had 60 docs leave and 2 docs come in.
Right. So net, we lost 58.
58, correct. And then...
I don't know why I said net. It's just net.
Yeah, net.
Why do people just like net? It's like triple net?
No. Okay. Then what happened in the December 24th, 2024, so Christmas Eve, we actually did the same thing. And we ended up with 174 doctors. So net of 114 doctors out of that first cohort left. 20 people came in, so you have 94 doctors net out. So out of that original cohort, 43% of the doctors left. And so what was interesting to me is
again, out of the original cohort, how many left?
So 114 out of 268 left, and you had 20 come in. So we were net down 94 docs. So here's a couple interesting points. When we started the study, the state needed about 300 obstetricians doing the work that is needed for the kind of population that we have.
And that was in 22.
22.
So we needed 322.
Yeah, probably slightly north of that now, 315, 330, somewhere like that, to take care of our population. The other thing that's been interesting is that we have this data, but we didn't publish it, is people said, well, that's how many people usually leave and come into the state every year. And we took a look at the 22 counties in the southwest corner of the state where we had accurate data. And it turns out in the 12 years preceding this study, the 12 years prior to 2022, so 2010 to 2022, on average, we had 2 people retire and 4 people come in every year. So what you saw in these 2 years afterwards was a big change from steady state prior to that.
Okay, back up. So you're saying in the 12 years preceding this, we had a net gain of OBGYNs in the state. And so you were saying 2 people were retiring, 4 people were coming in. So there were no, as far as the data you guys could find, there were no people stopping practicing obstetrics that stayed in the state, but they stopped. There were no people that were leaving the state for, whatever reasons.
Yeah, this study looked at all OBGYNs. So I suspect some of those people in there, the way life works for an obstetrician is it's a young person's game. So when the obstetrician gets 50 or 60 years old, often they will quit practicing obstetrics and go to GYN only. And so but that study didn't look at that. But what we were trying to do is having 60 folks leave in a year, is that normal or not? And so the 12 years prior to 2022, you had 4 people leave, they would retire.
Or 2 people leave,
yeah,
4 people come in.
Yeah, you'd have 2 people leave, 4 people come in, and it was one of those things where that was pretty much what happened. We don't have a residency in this state for obstetrics, and so every obstetrician who comes here has to want to be here, and usually they have some tie to this state, and they want to be here. And most states, I think you probably know this, Matt, is that when you go to residency, the years after your medical school, usually the people who do the work in residency stay there because they've got connections and all that sort of stuff. So if
they get a dog, they know where the good Chinese food place is. They're like, I don't want to move.
Right. Yeah. And we don't have an obstetrics residency in the state. And so every obstetrician who's here has to want to be here, and we have to recruit people to the state.
And regardless, there was, in the 12 years preceding, there was a steady flow of people stopping, retiring, doing whatever. Okay, fine. And whatever happened in 22 changed that dramatically.
Correct.
So for people to say, hey, we had a wave of people retiring, it's like, okay, that doesn't really make sense.
No.
Or that we were, whatever it is, whatever explanation people want to have, it's like, listen, for the 12 years preceding, this is what happened. There's no reason outside of the changing of the laws in Idaho to assume that that there was no shift. It's like if those laws hadn't changed, there's a high probability that everything would have continued the way it is. Now, again, whether or not people wanted that, irrelevant to me.
Yeah.
I just want to be clear that, look, we know for the 12 years preceding, we were losing 2 docs per year and we were gaining 4 OBGYNs. So net, we were increasing our OBGYNs. 2022 happens. And now sitting here in 2025, we can conclusively say we net lost the 94 doctors over that 2-year period.
Yep.
So whatever gains we made, and we can do real fast math, right? 2 docs a year for 12 years, that's 24 docs. We gained 24 docs from 2010 to 2022. And then we lost all of those and another 70
Yep.
in the 2 years that followed.
Yeah. And, one of the criticisms of our study, and it's actually by the study design, we didn't know what was going to happen. So we couldn't say, well, why did people leave? So we never did ask why folks left. We've got a study that's coming in the field soon that's going to ask the people who came into the community and the folks who left, what happened? Why'd you leave? And maybe it's because it's smoky, maybe because it's hotter in the summertime, or maybe because people wear wool socks and they like cotton socks. Who knows? But we will figure out what went on there. But there is I don't know if you could call it a cause and effect. There's a thing that happened, and then there's something that occurred after that makes one wonder, why did this change happen? So something went on.
We have a correlation, right? You understand studies. I don't, but I can sound like I do, but like we understand correlation. There was a terminal event. Something happened in 22 that led to this mass exodus.
Yep.
Now, if it can be explained by somebody in different terms, they're like, no, actually what happened, it was XYZ.
Yeah, it was more smoky than people wanted it to be in the state or whatever.
If I may ask, that would likely be observed in similar migration patterns in the rest of the medical field.
Yeah.
Right. So, like, say you have a proctologist, right? You have a certain number of proctologists in the state, and you would assume that if there was some environmental factor, that it's like, hey, we lost 20% of our OBGYNs and we also lost 20% of our internal medicine, all these things, because this became a bad environment for them, whatever it might be. There's no other field within the medical field in Idaho. There's no other specialty, within the medical field of Idaho that saw an exodus after 22, correct?
That's my understanding, yeah. The data I know, it's getting harder. Dr. Perry Brown, who you had on the show,
Yes.
who did a great job, I thought, with you, and by the way, wonderful job with him. Has noted it's harder to recruit family medicine people to residency and pediatricians to a residency into the state. Now, again, why is that? One could hypothesize or postulate there's some things that happen in the environment that makes it hard. And I think that it's probably a reasonable hypothesis to go test that. And we are. And so I think that we can get to a spot that we'll actually know definitively that A caused B. But we know that A happened and B happened, and you can infer, any reasonable person might be able to infer things are going on here. They're a little different from a steady state 12 years back.
Right. Now, to be clear on a couple things regarding Idaho medical problems, like we have been the worst or close to the worst in the country with medical access for decades.
Yep.
Right. So one thing I was chatting with somebody about the other day is that it's like, okay, look, we actually have an OBGYN shortage nationally. Right, that we have fewer people going into it, fewer people interested in engaging it. And because of that, we're dropping down. So we don't have enough OBGYNs today to serve our entire nation. Now, factor in that you're now dealing with a nationally scarce resource. You were already one of the worst recipients of that resource for, again, we don't have a residency program, right? That makes it very hard to get people to come into the state because they're likely going to stay where they did their residency. That's just statistically how it works. So we don't have a residency program here. We're already starting lower than everybody else, which means that we are overly stressing the existing supply of people we have because they're dealing with more extreme cases. They're dealing with more cases. You might have a very upsetting outcome of a pregnancy. And in a state that's populated with enough OBGYNs, you have a distribution of those upsetting cases across, so everybody's essentially carrying the weight of like the stillborn, child and things, very upsetting things like that. When you have a shortage of those, you get a concentration of those onto the existing. So you're like getting 2 or 3 times the number of, emotionally or just difficult situations. So you burn out people, and they're working longer hours because you have more people trying to see them. So we already have this like very, very difficult situation for an OBGYN to come into, and we have a national shortage of them. And then we ostensibly have legislation, or it would seem that we had legislation that made it even more difficult.
Yeah, it's interesting. One of the things this study showed was that if you take 114 people or 94 people out, the average obstetrician will see between 2,000 and 4,000 women a year. And if you think about that for a minute, so let's call it 100 people are out. You're now down 250,000 to 500,000 visits for a woman in the state that used to be there. And so if you talk about outcomes, the first part about outcomes, to prevent a bad outcome, you have to be seen first. So access is important to be seen. One of the other things that happened in this study is that when we looked at the practice sizes, 85% of the obstetricians practice in the top 7 counties in top 7 largest cities in the state. That leaves 23 docs for the rest of the 44 counties. And
Say that again. So you have 85% of the practicing 174 doctors
in seven
cities. That means for the other 44 counties, you said?
Yep.
There are 24?
There are 44 counties. So the other counties outside of those 7, there are 23 obstetricians practicing. So now you've got, one of the things that we see is that it's a tragedy in the urban areas. You'll be seen. It may take a while. It'll be hard to get access. If you're in one of those communities where the doctors left and there's no doctors left in that community, it's really hard. The access becomes incredibly difficult to get. One of the things that we saw is that if a practice gets 5 or below doctors in it, it's hard for that practice to cover 24/7, 365 call. As a physician, we're on call. We don't think about it much, but you go down to the emergency room and you'll get seen by a doc, and that emergency physician can call some specialist, any specialist that they need to, 24/7, 365. In order to do that, to staff 24/7, 365, you have to have a minimum of 4, better is 5 doctors to do that. If that practice gets below 5, somebody retires or somebody decides to move on, and you have 3 doctors, that means every third night, one of those doctors is on call all night. And you can't do that very long as a physician. It's just not tenable, given what you just talked about, how the burden of care and the severity of care has gone up. So not only are you on call more, the cases that you're seeing are more difficult and they're more frequent. And so it's harder to maintain that kind of lifestyle if you're in an ex-urban or frontier community.
One thing that people have talked about that is dissuading OBGYNs from coming here is there are a lot of things that are even unrelated to medicine, which has kind of blown me away, like housing cost, right? Like, and especially within rural areas. You have a lot of rural areas that are very attractive to, let's say, out-of-state retirees. Those people move in with inordinately large pensions or disproportionately large pensions compared to localized ones, drive up housing costs. They're also retired, so they're less likely to vote for school bonds and things of that nature.
Right.
So you have decreasing of education funding, localized education funding. You have increasing in housing costs. And then because you have a lot of retirement areas, the reimbursement from Medicare is actually lower than standard practice. So you have this triple effect where you have individuals trying to be enticed to areas. They're like, let me get this right. I'm like a 35-year-old doctor, right? And you want me to come to your area. The housing cost is astronomical. I'm going to get reimbursed at a lower rate. And my kids that I love and I want them to become educated, they're going to get a worse education because nobody's funded the schools around here because it's, older people and they have a lower propensity to pass those bonds. So those are things that are already dissuading people from coming in here. But a lot of that can be resolved with pay.
Yeah.
Right? How do we get more money to doctors? Like, is there any way to do that?
One of the ways, a lot of doctors right now are employed by health systems. And,
Sure.
And so, one way to do that, most of the classic way a doctor got paid back in the 60s and 70s is fee for service. You did a thing, you got paid for the thing.
Sure.
And now a lot of the money that we have coming through systems is value-based care type dollars, meaning that we pay people The health insurers give the health system a block of money, and they say you got to take care of these patients here for that much money. Good luck, and go at it that way. And that allows the system to take a look at where it has the needs that are great and begin to give doctors maybe a salary that's commensurate with what they could get in a different state, or entice them to come to this state with a little bit more money than they would get otherwise. One of the things that's true, though, is that there's a finite amount of money in the system, and it's hard to allocate those dollars in a different way. One of the studies we've got in our set of studies we're doing is, why do people show up here? I mean, there were 20 people who came here, so maybe we could learn something from them and figure out why they came here and get more people to come here. Since I think this net 94 loss is a generational change, it's going to take a long time for us to get back there. So what does better look like? Well, maybe we need to figure out what it was that brought these 20 doctors here. There were about 22,000 babies born in Idaho in the last decade. Every year, it's kind of crazy. The birth rate is going down, people coming in. 22,000 births a year is kind of what we're seeing. 19,000 of those are done by obstetricians. About 2,300 are done by family medicine OBs, and about 3,000 are by nurse midwives. So maybe if we're really concerned about the healthcare outcomes.
Did you say 3,000?
About 3,000.
By midwives?
By midwives, yeah. And so maybe what we need to do is figure out how to safely back up and get midwives and family medicine OB docs to the point where they feel comfortable delivering the kind of babies that maybe an obstetrician would do. But you've got to have that backup. When things go bad, you need an obstetrician to have that backup.
Well, not only do you need that, it's my understanding, because listen, I'm not disagreeing with anything you're saying, but it's also my understanding that it's like, okay, you need an obstetrician when you're delivering, be just for backup, but you also need a surgery center.
Yep.
Real damn fast.
Yep.
Because when you are delivering, if it comes to the point where like, we need this kid out right now, you need to be able to do it, and you need to be able to do it well, and you need to be able to do it in 90 seconds.
Yep.
And in the event that you don't have that, this is where we have like catastrophic, horrific stories. And again, you can say, well, okay, how often does that happen? Well, how often would you like it to happen where, you have this need for a surgery center or different sectors of healthcare that aren't classically or on average involved in births, right? But you really need them when you really need them. So how many midwives would solve the problem? Well, as many midwives as we could pair with a surgery center.
Correct.
Right? As many midwives as we could pair with an obstetrician that's, maybe overseeing 5 or 6 different births at once. But I've had experiences with birth. I have 3 boys, and midwives may or may not have been involved. I'll just say it that way. And,
okay.
There are times when it's like you would see a specialist kind of poke the head in and instead of a thumbs up. And, so you knew that there was somebody that was like a hyper specialist floating around,
Yep.
Overseeing this. But that doesn't
supply.
It doesn't replace, it's not the answer.
That's right.
I have heard a lot of people say, get family practice doctors to like specialize in this. Like, that's fine. You still need all of these other systems in place, or you should not be delivering children.
The point you're making is a good one, which is that we operate in a system, and what we've done is made that system more brittle and fragile. And there are appropriate roles for those people who, midwives and family medicine OBs. Sure. But OBs, obstetricians also have other colleagues that they work with as well, perinatologists and neonatologists who are super specialist OBs. And those are rare in this state. And so what you've just said is that we need this system to work. And so if we're making the system fragile, that's not a good thing. And so, if I think we are where we are, there's not a way we're going to easily go back to where we were before. So my question becomes, well, how does better get, where do we get to better, and what does better look like? And I think the point you made is actually bang on. That system needs to be durable and weight bearing, and it needs to figure out a way we can function with less people. And the quickest way, I think, to do that is to pair busy obstetricians with people who have enough experience, so that when things unfortunately go bad, they do have that kind of backup around them.
Yeah, and you see this in other fields of medicine. For instance, like health spa stuff, right? You can have a nurse practitioner that has like a Botox, laser, wrinkle removal, blah, 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 like all these things that is overseen by a medical director. But the nurse, I know that a friend of mine sells or used to sell medical devices. And he was like, oh yeah, I sell them. He would explain the whole nature of it, which is you have somebody who is, in fact, a nurse practitioner, but they have an overseeing, medical professional that essentially signs off on everything. And then the nurse practitioner just makes bang out money doing, Botox or whatever the heck she's doing, right?
Yep.
He or she's doing. So the point is that if we had a similar system for this, where it's like, okay, look, let's leverage the expertise of each OBGYN and supply them with all of these supportive professionals and systems so that we don't necessarily have to get to the 300. Because as you point out, it's like there is no quick road to 300.
Right.
That's not going to happen like maybe even this decade, right? Like we're not getting back up there. But what we can do is stretch the resource more.
100%.
Okay, then how do we get more midwives and, family practice OBs here?
That's a great question. The House Bill 333 that's going through right now, there's a study group looking at for reproductive medicine. I think I understand this, but I'm not sure. Is studying, what would actually answer that question. How do we actually do that? In my small mind, and the way I think about this is use the resources you have and figure out what you can do to stretch them and back them up. Anesthesia is a great model. There's some very, very competent nurse anesthetists who do very good work, but they always practice with an anesthesiologist nearby. And so what that does is it allows the expertise of an anesthesiologist to be spread over a number of different rooms with highly competent individuals focusing well inside their scope of practice. And so if we do that same sort of thing, we've got to figure out how to do that with obstetrics. There are other barriers that we have to take away over the longer haul that'll take a longer way to do that. One of them might be, could we create an obstetrics residency here? That'd be great.
Seems like just such the right answer.
Right? I mean,
but then the barrier is first off, you need people to voluntarily engage in it. So you have like this already overworked population of physicians practicing obstetrics, and then they have to agree to teach other people to do it.
Yep.
You also have to get funding for them. Like you have to get locations.
Yeah.
I've asked this question 1,000 times. Like, why can't we just pull this off?
it's a whole thing. I mean, it's a whole thing.
It's a whole
And it may take 6 years or whatever. But I mean, I think ultimately that might be the answer. I mean, we're one of few states that doesn't have an obstetrics residency. If you had an obstetrics residency, people would come here who wanted to be in Idaho, who wanted to practice obstetrics. They understand the environment,
Right.
and they would do that. But that's a long time off. So how do we get from here to there, given where we're going?
Don't ask me, man. I got black coffee. That's all I got. It's like, I got a lot of enthusiasm and energy. I don't know what the answer is. And I am not here advocating for one policy over another for Idaho. I think 100%, again, I had Melanie Falwell, who's running the Idahoans United for Women and Families. And that organization is trying to get an initiative on the ballot for 2026 that would allow for, I don't know all the nuances, but it would allow for abortion, right? And it would allow for, somebody, both medical and non-medically necessary abortions. Okay.
Yeah.
And I don't know the term limits or time limits. And again, for or against, that's not me. What I do like is that we would allow Idahoans to make it clear what they want. Now, some people have already said we did make it clear. We elected people that, are representative government that went forth and did this thing. It's like, okay, that's fine. And I hear a lot of people saying that doesn't represent my sentiment or that doesn't represent what we think. So conclusively, if Idahoans vote like, no, this is the right thing for us, okay.
That's
and
fine.
if they vote and they're like, no, this is not the right thing for us, okay. Ultimately, we will know what Idaho wants, and that will be represented. Okay, great. For or against, doesn't matter. But then also we just recognize, okay, this is where we are as a state. This is where we are as a population and a culture. And how do we iron out a path forward so that my wife and potentially your wife, I don't know if you're married, and hopefully at one point my
daughters, yeah.
My daughter-in-laws, I have 3 boys, daughter-in-laws, friends, all of these people have access to medical care that they want. Because, when you lose somebody, when you lose an OBGYN, sometimes you lose the GYN aspect of it too. Now, there are cases through this study, it's my understanding, where people stopped practicing obstetrics and just moved into gynecology. And it's like, okay, well, that's good.
Yep.
But then we also just lost people conclusively. It's like, no, they're gone. They're out of the state. They're like gonzo. That's not good.
Not good. It is kind of interesting that one of the things that you said there is that, you know, we need to have a system that works, and we need to create an understanding of what it is that we're dealing with in reality. And one of the reasons why we did the study is in a prospective manner, because we didn't know what the answer was going to be when we started. We had a hypothesis that something was going to change.
So that's perspective. What is it when you think you know what the answer is?
We could have a hypothesis about what we
Gotcha.
had, but we didn't know. So we,
Gotcha.
and the beauty of this study, very powerful part of it, is that we just said, let's just count them as we go. And we, in a retrospective study, is to go back to start now and look back in 22.
But you started in 22.
We started in 22.
Like,
and said,
let's see what's going to happen.
exactly. Don't know what's going to go on, but we can think something's going to happen, and that's really powerful. The thing that is really important is that we have accurate data to have a conversation about what is, because if we don't have accurate data, we don't know what is, and we can't solve a problem we don't know. And now we know what the problem is, and we've defined it. Do we know why conclusively? No. But we actually understand where we are, and we are where we are. So let's figure out what better looks like and go there. And that's the kind of the thing that I want to figure out. Now, what would be interesting to know is, interesting between 23 and 24, between the time windows we had in the study, there were 54 people who quit practicing. Actually, between December 24th and the 1st of January, one other person left. So we had 55 people leave the practice in that time window, and we followed where they went. So 23 of these people went to other states who are still practicing obstetrics. And so what I want to know, and from all that 55 people, that cohort, survey them and say, hey, what happened? Why? Was it smoky here?
Yeah, right. Why?
Why? What happened? Why did you leave? And we'll learn a lot of things that you or I probably have hypothesis about, but there's a bunch of stuff that went on that we probably don't know. And they'll tell us what's going on. Well, that's important if we're thinking about policy and about recruitment and about changing things in our environment, so we can create something that attracts people to this state. Because if there's things that we're doing that are bad, we need to quit doing those. And if there's things that we're doing good but not good enough, we need to do more of that. And I think it'd be helpful to move those people, to help them help us move people to the state of Idaho to do the work that we need to do.
Man, this is intense.
It's a big thing.
It's a big thing. Listen, I know it's a working day. You took time out. Thank you for coming in to explain this. Is there anything you'd like to hit here at the end?
I appreciate your pulling this out here. I think one of the things that happens in this conversation, it gets politicized and it becomes polar, one thing or another. And I think the thing is, we don't really know what we don't know. And I think we need to figure out, we're all in this together. We need to figure out a table where we can have a cogent conversation about solving the problem that's in front of us. And it's not a problem that's going to go away, and you can't, gaslight what it is that we're doing right now with the limited number of obstetricians we have in the state. So instead of figuring about faults and all that kind of stuff, figure out what better looks like, and let's go there. Let's get busy getting better instead of trying to figure out where the blame is. And so that's the whole thing for me, is that I really think that the citizens of the state deserve to have, I would love to have the state have the best maternal and fetal outcomes of any state. And in a state like this, we could probably get there, but we're going to have to do that together. And that's the thing that I think is important.
Where, as far as outcomes, I know statistics on access, but as far as outcomes, where does Idaho land for maternal and fetal outcomes?
We don't know that number well. And it's hard to get that number. In some states, there's compelling reporting around maternal and fetal outcomes. This state's not one of those that has an all-payer database that allows us to do that work. So we don't have great data on what those outcomes are. It's unfortunate.
Gotcha. Well, Dr. McEachern, I appreciate you. Thank you for coming in today.
Pleasure,
and
Matt.
I'd love to keep the conversation going as you guys get more data compiled up, just so, again, we can sit at the table. And people can dismiss whatever, I just want to hear the data, very much like you. And to be clear, you're a pathologist, you're an internal medicine guy, you're not even an OBGYN. You just studied this thing and published a paper.
I don't have a dog in this fight.
Yeah. Well, aside from just caring about getting the truth and reality of the situation out and then letting Idaho go from there.
100%.
Yeah.
Thank you, Matt. I appreciate it.